Hello and welcome to today's session on wound assessment. I'm Jen Letchford and I'm a tissue viability nurse with Coloplast. I'm hoping that from today's session you'll have more of an understanding of the importance of holistic wound assessment. This module is actually endorsed by the Tissue Viability Society and is taken from one of our larger Coloplast Professional Heal modules. The content that we'll be covering today, we'll be looking at the importance of wound assessment, patient assessment, the actual local wound assessment, and how we document our wound assessments. So after completing this course today, you should be able to really identify the importance of undertaking a detailed holistic assessment and patient history, identify any of the barriers to healing, and accurately document the wound assessment that you've undertaken. So we'll start by looking at the importance of wound assessment. I'd like to introduce you to Camilla. Camilla is a patient of Coloplast's who lives in Brazil. She's an 82-year-old lady, she's a grandmother, and she's got a venous leg ulcer. And actually, what we need to take into account is that we're not always looking at the wound. We need to look at the bigger picture, and this wound affects that person's life. She's a grandmother, an aunt, friend, colleague, and we need to look at the holistic approach so that we can give her the best possible outcomes.
As a healthcare professional, I'm always looking at ways that I can improve the lives of the patients that I care for. I see a lot of patients in clinic. They come from all walks of life, from different ages and different backgrounds. No two patients are the same, and each patient will have a different perspective on their wound type. But the thing that unites them all is that they want to get better. They often feel helpless and isolated, and they can't live the lives that they want to live. I want to work with those patients to help them get better. When I get to work, I know that this will be at the top of my patients' minds, and I want to work with my patients to give them the best quality care to improve their lives.
So you can see there the importance of wound assessment and involving our patients within that wound assessment. And if we don't do that and there's an inadequate wound assessment, it leads to the inability to identify some of the factors that may be delaying healing, which can also lead to inappropriate treatment choice for our patients. And if we choose an inappropriate treatment, there can be other complications such as infection or poor exudate management leading to increased risk of biofilm and infection, or the overall delayed wound healing, meaning that the patient has to live longer with a wound. Wound assessment can be challenging, and there are a whole multitude of factors that we need to look at. The specific wound factors, patient factors, any educational factors. So do we have the skilled clinicians to be able to assess and treat these wounds? And then any of the organisational factors. Have we got procedures in place that support us with our wound assessment and treatment of wounds? So looking at each of those in a little more detail, the wound factors themselves, what is it that we're looking for? We're looking at the wound depth, the wound size. How long has that wound been there? Has the patient got poor tissue perfusion? Is there any necrotic tissue that might need debridement? Are we looking at high bacterial load and infection that needs management? Do we have any edema present within that limb or surrounding the wound? All of those things will have an impact on the healing, and they're all things that we should be looking at as part of our wound assessment. Then we move on to the patient factors. Do they have any comorbidities? Are we looking at a patient that's socially isolated, might be suffering with depression, for example? Or those types of things can, again, have an impact on the ability to heal a wound. So we want to be starting to build this picture of what's going on in our patients' lives, what the wound itself looks like, and try to get to the bottom of any barriers that there might be that are preventing this wound from healing. The educational factors. Are we looking at up-to-date clinical practice, evidence-based practice? Or actually, are we treating a wound because that's the way we've always done it? Is it a holistic assessment that we're undertaking, or are we just reverting back to what we've always done? We need to be thinking outside the box when we come to wound assessment, making sure that we've got the education that we need to be able to support our patients on their healing journey. The organisational factors. Have we got an effective team in place that are an appropriate skill mix, that have the clinical guidance to underpin what they're doing? Do we have a consensus between us in the team of how we're managing these wounds? Are we all using the same standard procedures and standard assessment tools effectively? All things that we need to consider as part of the overall assessment process. So, development of wound assessment and frameworks. Well, over time, the concepts have changed slightly. You can see on the timeline here, in 2000, we looked at wound bed preparation and the importance of actually the focus on the wound bed itself. Then we move on to the time concept afterwards. Wound bed preparation, the model, was really looking at whether there was any debridement needed, or the bacterial bioburden, edema and exudate presence, and what it is that we need to do to overcome those challenges. So time then looked at the time as an acronym. So tissue, is there any non-viable tissue? Is there an inflammation or infection present? What's the moisture balance like within our wound? And how are the edges of the wound looking? How do we treat the edges of those wounds? We then come on to the more recent triangle of wound assessment from 2015, which looked at not only the wound bed and the wound edge, but also incorporated the periwound skin as part of the full holistic assessment. So adding slightly more detail to the time concept that we had previously been using. The triangle of wound assessment looks at the wound bed, the wound edge, and the periwound skin. Those three areas that really have an impact on the overall wound healing. So we should be assessing each of these individually, looking at the key areas within each of these sections. So wound assessment, for example, we should be checking the tissue type, whether there's any necrotic tissue that needs debridement, whether the exudate levels are low, medium, high, and how we would manage that. Is there an infection present, for example? Then we move on to the wound assessment part of the periwound skin. So what's going on surrounding that wound? What's our treatment objective? Do we have some maceration that needs management, or do we have dry skin or hyperkeratosis present? Then moving on to the wound edge and looking at what's going on. Is a wound dehydrated? Have we got some undermining or tunnelling? All of these things will help us to build a picture as to what's going on with the wound, why it's got to that stage, and what we can do to help move it on its healing trajectory. So these three key areas allow you to develop a management plan. And I've given some examples of the types of things that you might see, whether that's slough, non-viable tissue, infection. So by finding those things and working out what's happening in our wound bed, we start to gradually unpick what we can do to remove those barriers to healing. Maybe it's removing the devitalised tissue, or we might need to think about antimicrobials to treat a localised infection. So we're starting to devise this management plan to help our patient. So as we go through the rest of this course, I'd like you to take a moment and just think about patients that you're currently treating and currently seeing, and try and put together some of the questions that we're going to be looking at in this assessment presentation to see whether they're the types of things that you're covering with your patient when you're undertaking a full holistic assessment, or are there things that actually we could improve on and we could do better. So we'll move on now to patient assessment. The gathering of the information. It's really important to undertake not only that wound assessment, but a holistic assessment of the patient, identifying any underlying comorbidities, anything that we need to look at to remove the barrier to healing. And that really is done by listening to our patient, taking a patient history and identifying what the primary cause is and trying to remove any problems associated with that. We're going to be incorporating all of our senses to undertake the assessment. So we're going to be looking, we might be touching surrounding skin, checking temperature, using our sense of smell to what odour are we smelling, if any? Is there something more going on there? Listening to our patient is key. Finding out what our patient's main concerns are so that we can help set expectations with our patient from the very beginning. It also helps us to identify any factors that are delaying healing and helping to build that rapport with the patient to try and get them on board and get them involved in their care. The gathering of information really is key to our role as nurses and healthcare professionals. Exploring the patient's problem with them from their perspective will help to identify the reason why the wound has developed, which can also help us to manage the wound longer term. For example, if somebody has a reoccurring leg ulcer and they're coming back to you in a clinic every 3 months or so, you get them healed and then the same happens again. We need to get to the bottom of why that's happening. And is that happening because somebody stopped wearing compression hosiery, for example? And actually they might need just a little bit more education on why it's important for them to continue to wear that hosiery. So listening carefully, using appropriate questions, starting with our open questions, not leading our patients with this. Hearing things from their perspective will really help to identify the causes of this wound. Encourage your patient to talk to you. The quicker we can find out what the cause is, the quicker we can help support this patient and get them on the right management plan to heal their wound. We could use some closed questions after we've listened to our patient to just clarify with the patient what we've heard, to summarise, if you like, what they're telling us, to make sure that we've got everything that they want us to hear. And then what we need to be doing is gaining more insight into the patient's concerns. So what is it that they're most worried about? How many wounds do they have? Have they got any other skin damage surrounding these wounds? How long have they had them and lived with these wounds? We find that some people, and I remember in my clinics, people would come in and say, oh, I've been managing it myself for about 6 months now, dear. Well, in that 6 months, what have they been through? What have they tried on that wound? And actually, why have they had it that long? What else can we do to try and prevent this wound from being here any longer than it needs to be? So any factors that might be exacerbating the wound, it gives us a real insight when we are talking to our patients and being able to look at the associated problems that we might be finding. We also need to consider medications and which types of medications people are taking. Are they taking them when they should be taking them, if they're prescribed medications? And actually, for example, if somebody is diabetic, if they're not taking the appropriate amount of insulin regularly and their blood sugars are unstable because of it, that will again have a knock-on effect to our wound healing. So listening to our patients, asking questions to obtain as much information as we can from them, not only about their wound, but about their general health and overall well-being. What do they think has caused the wound? Quite often patients will be able to identify what's caused a wound. For example, a wound on a foot might be because they've worn shoes that are ill-fitting and it's caused pressure damage, for example. So they might be able to help you identify what the cause of the wound has actually been. And once you've identified the cause, you can then try and remove the cause of the wound. So in turn, that helps the wound to heal more quickly. So we want to be completing a top-to-toe examination, not just focusing in on the actual wound and wound bed that we see, but looking at the patient as a whole, identify any other concerns that the patient might have, and this is going to help us to diagnose what's going on with this patient and come up with an appropriate treatment plan to manage that wound and to manage the challenges associated with that wound. So when we're using touch to help with part of our assessment, this can be things like checking pedal pulses, for example. We don't always need to be wearing gloves to do something like this. Obviously, I wouldn't suggest putting a hand directly into a wound if you're not wearing gloves and it's not sterile. So I wouldn't suggest that. However, we can be using touch to check, as I said, pedal pulses, and we don't necessarily need gloves on to be able to do that. The gloves can actually inhibit what we're feeling. So we need to be conscious of that as we're undertaking the assessment using touch if we're going to. There are benefits to being able to touch and get hands-on within our assessment. We can check whether somebody's skin is dry, whether it's rough, dehydrated. We can feel for pulses, as I've mentioned. We can check to see if a person is receptive to pain or receptive to touch. Have they got a numbness or a burning or tingling sensation? On the same hand, we can also see if the limb in question is very cold. Is there a poor tissue perfusion? Do we need to be referring on then to somebody else to undertake a more thorough assessment of that cold limb, for example? So touch can be really beneficial as part of our assessment. Then when we're looking at our patient and actually using our eyes, we do it all the time. I know I can be out in a supermarket, see somebody with a wound, and I'm automatically looking to see if they've got any edema or if they've got varicose veins, if it's on a lower limb, and I'm building up this assessment in my mind without even consciously knowing that I'm doing it. So the information we can gather just by looking at somebody's skin and looking at somebody's wound, or looking at somebody as a whole, is really important. We can know a rough idea of age, body weight, are they mobile or not? So all of this plays, again, a big part in the healing ability for a patient. When we look at people's skin and look at the observations, the observations that we're making, that will again in turn help us to diagnose what's going on with a patient and to confirm what's happening, to be able to come up with the most appropriate treatment plan for this patient in question. We do need to be really mindful of a patient's dignity when we're undertaking these types of assessment. Some people will find it embarrassing to have a wound, for example, and we're then sort of having a really close look at this wound and examining the wound, and they might be really uncomfortable with that, which is why it's important to really listen to your patients and try and build that rapport with them. So the other things that we're looking for, so some of the observations that we're looking for on a dressing when we're removing a dressing, for example, would be how wet it is, what's the exudate levels like, is there an odour? But if we're using just sight, we should be able to see whether it's dry, moist, wet, completely saturated, or whether there's leaking onto clothing, for example. And that will give us a good idea as to whether the management plan that we currently have in place is appropriate or not. And then the smell, the odour associated with the wound. How much are we actually smelling? Is there a malodour? Are we experienced enough to notice the difference between maybe a wound infection or a malignancy, for example? Because there are slight changes with the odour of a wound depending on what's going on with it. So it can be really useful to us to be able to smell a wound and gain the insight from that. So it's one of our human senses that we're using, again, subconsciously a lot of the time. I know that if a patient was to come into a clinic and they've got a pseudomonas, for example, I'm sure some of you will agree with me that you can almost smell that as somebody walks through the door of your treatment room, or if you're doing a home visit, you can almost smell that as you enter somebody's home. So it can be a really powerful tool to us to help with part of our assessment. So just looking back at what we've covered so far, I would ask you to have a think about some of the questions that you might then ask your patient based on what you've seen today. Are these all things that you ask your patient during your assessment? Are you really building the rapport with the patient and asking them for the most important things for them and setting those expectations? Are you taking into account any comorbidities or medications? So just have a think about the things that you do cover and whether there are any gaps in maybe your current practice that you could look at differently after today's session. We're now going to look at the local wound assessment and the importance of that. So the aim of the wound assessment itself is to identify the cause of the skin breakdown, identify any associated risk factors, and correct or treat any underlying cause. Pressure damage, for example. Is it because somebody is sitting on an inappropriate surface, and do they need a pressure relieving device or piece of equipment to help with that? We need to try and identify appropriate treatment options and control the symptoms for the patient, because it's not nice living with a leaking wound, for example. So as well as it causing potential for exudate pooling and maceration, infection, and the cascade of challenges that comes with a poorly managed wound, it also has a knock-on effect to the patient and their quality of life and their everyday living if they're having to change clothes multiple times a day because they've got a leaky wound, or change their bedding, or they're not going out and seeing people because of the wound exudate. So it's really important to identify the underlying causes and the problems for the patient. And the outcomes of our wound assessment. Really a thorough framework, which we've outlined in this course, the three-step, the triangle of wound assessment, will mean that clinicians can assess the wound and skin integrity, the whole person, which will result in an individualised, meaningful and comprehensive assessment, leading to appropriate treatment choice, which will improve the effectiveness for the patient. It will identify the patient's expectations from the very beginning, and it will facilitate a better communication with our patient, meaning that the clinical outcomes will improve and be more achievable. So our diagnosis and wound characteristics, again, things that we need to look at. So we can do that by asking the following questions as well as doing our physical examination. How long has the wound been present? What's the nature of the wound? What size is the wound and depth is the wound? Is there tracking, undermining and tunnelling present? Are we seeing necrotic or devitalised tissue in the wound bed that we need to do something about? And the condition overall of the periwound skin and the whole limb, really. If we're looking, for example, at a lower limb wound, is that dry skin? If they're hyperkeratosis, if they've got lymphedema or edema present? So we can really use these tools and questions to identify the causes and confirm the causes of a wound. So a detailed wound assessment really is key, and it should take into account our evidence-based practice. We should be looking at the cost effectiveness of our treatments and to look at the resources available locally to us. The first step in any wound management is to assess the person as a whole and the wound. That will help us to identify treatment and appropriate treatment, and we can then implement the appropriate treatment before going on to regularly reassess and change any treatment objectives as we need to, as we go, and as that wound begins to progress to healing. So wound assessment using the triangle tool. We're looking at the wound edge, wound bed, and the periwound skin. It's really important that we're looking at all three of these areas, because each of these areas really does have an impact on the wound healing. It will help us to identify and devise that optimal management of a wound, and it will help us with our really appropriate selection of product use. So, using this tool, it's important to also document what we're seeing. And we need to be documenting the wound location, the size, the depth, how long it's been there, and to identify what we feel is the likely cause of a wound. Documentation is key. As we all know as nurses, if we don't document it, then in theory it didn't happen. So it is a legal requirement to document what we're doing as part of our Nursing Midwifery Council guidance. So recording the wound size and depth, we've got lots of tools available to us. We might want to use a ruler. We might want to take photographs to monitor a wound. We'll be looking at any undermining or tunnelling and may want to use a wound probe. And we should always be using appropriate tools that are identified for that purpose in order to measure wounds. So moving on to our wound bed assessment in a little more detail. When we're looking at tissue type as part of our wound bed assessment, we need to identify what the majority of the tissue type is that we're seeing. Are we seeing necrosis, sloughy tissue, granular tissue, or the final stages of healing in that epithelialization? So necrotic tissue is either soft, wet, hard, dry, but it's normally black or darker brown in appearance, and it's devitalized tissue, it's dead tissue. It contains the dead cells and debris, and it can collect on the wound surface and actually prevent the wound from healing. If you've identified poor tissue perfusion, that can also sometimes be linked with the rapid onset of necrosis, which can spread quite quickly. So necrotic tissue does delay our healing, and it can lead to higher risk of infection as well. It's something that really carefully needs to be removed from the wound bed in order to help the wound progress through its healing trajectory. Sloughy tissue. Again, it can vary in colour, but it's normally yellow or has a slight grey or green coloration to it. And we want to be removing this devitalised tissue from a wound bed in order to support the wound healing and create an optimum wound healing environment. Then we look at granular tissue. It should be pink or red, and it's that new connective tissue with the new formation of blood vessels sitting at the surface, which is really helping the wound to progress towards the final stages of healing. Granulation tissue sometimes can appear quite friable, and it can bleed quite easily. And that's sometimes an indicator that you've got a local infection or biofilm presence potentially. And that can then delay the wound healing. So we need to be able to identify whether it's healthy granulation tissue or whether it's granulation tissue that might have something else going on with it as well. Then the epithelialization. It's that white or pink tissue seen at the final stages of wound healing, and it might be migrating in from the wound edges, or you may see these little islands like you can see on the screen here. But it's at this stage where the wound is really getting towards the final stages of healing. And we really need to be supporting this with a moist wound healing environment and making sure that we're managing those exudate levels in order to provide that optimum environment to continue that wound healing. I've mentioned throughout that exudate type and the level of exudate is also really important when we're looking at our wound bed. Again, it's key to manage this exudate. And actually, exudate can be low, medium or high in its levels. And each of those would identify a different dressing type needed potentially. We also should be looking at the consistency of our wound exudate. Is it thin and watery, or is it thick, cloudy and purulent? Again, this can help to identify any factors, underlying factors going on with the wound, and make us look at what we need to be doing to help treat the wound. It can be a sign of infection, for example, if we've got that thick, cloudy and purulent wound exudate. So it can tell us a lot. So it's something that we really do need to be observing. Again, it can vary in colour slightly. So you've got that clear yellow or potentially even red, pink or red exudate, helping us build a picture as to what's going on with that wound and what our best form of treatment might be. We then look to see whether there's any infection present within the wound bed, and some of the local signs of infection would be increased pain, erythema, some edema possibly, malodor or pocketing in the wound. And then we move on to the slightly further on the infection spectrum, looking at spreading or systemic infection, increased erythema, patient having a temperature, have they got pus or an abscess present? Is the wound really starting to break down? Is the patient becoming systemically unwell? All things that should be considered as part of our wound bed assessment. If we're looking at a non-infected wound, it will appear without any signs of infection, and it shouldn't be painful. It should be reducing in size and really along the lines of that healing trajectory. It's a healthy looking wound. So just summing up on the wound bed assessment, we should be able to notice what the tissue type present is, whether there's any odour or not, how much exudate and what colour and kind of exudate we're seeing. We should be able to identify any signs of infection, as well as checking the depth of the wound and the structures of the wound that are visible to our eye. So in this wound, for example, you can see tendon, and actually, again, that would help us to identify that there's some depth to this wound that we need to be managing. So we need to document all of these things, and as part of the triangle of wound assessment, there is an easy way, a simplified way of documenting this, as you can see on the screen at the moment. We then move on to our wound edge assessment, and we're looking at whether there's any maceration, dehydration, undermining or rolled edges to the wound. So maceration is that waterlogged tissue that might appear white around the edge of the wound. And it's indicating actually the exudate isn't being managed appropriately, and it's causing that damage to our wound edge. If a wound is dehydrated, then if the wound edge is dehydrated and you've got that diminished exudate production within the wound, it's going to have a knock-on effect and delay that wound healing process. The undermining of wound edges can indicate that actually that wound has been there for quite some time and it's probably a chronic wound. So what do we need to do about that to try and help this wound move on in its healing? Or in our deeper and larger wounds that may have those rolled or thickened edges, they're quite difficult to heal sometimes, these types of wounds, but we need to be getting them into that optimum healing environment as best we can. And we can do that by helping to identify exactly what's going on with the wound. So just summing up on the wound edge assessment, we should be able to notice whether there's any maceration, whether there's signs of dehydration, undermining and tunnelling, or whether there are any signs that would require further investigation, such as those rolled edges and with a chronic wound. Is there something more that we need to be looking at with that patient? We then also need to really clearly document what we've seen on the wound edge. And again, the triangle of wound assessment documentation tool, you should be able to do that quite simply. Then the peri-wound skin assessment, looking at the surrounding skin to the wound edge. Is it macerated? Is there excoriation, dry skin, hyperkeratosis, callus or eczema? All of these things can have an impact on the wound's healing ability. So we do need to be extending the concept of wound assessment right out to that peri-wound skin. So maceration we have already mentioned, but it's the thickening and the softening of skin as a result of that prolonged contact with wound exudate or moisture. It's quite often white in appearance and can be quite painful for our patients as well. And you can see in the picture here that the wound exudate really hasn't been managed very well, and what's happened is that exudate has caused maceration to the peri-wound skin. And you can see that there's still quite some level of exudate sitting on that peri-wound skin at the moment. Then excoriation. It's caused by that repeated injury from the surface of the skin, possibly through scratching. So if you've got somebody who has an eczema and they're finding that their skin is very dry and it's itchy and they're scratching, that can cause excoriation. So we might want to use emollients, which can interrupt that itch-scratch cycle and help to improve our skin's barrier functions. Dry skin. Dry skin often is quite itchy, again causing a person to scratch and really damaging that protective layer that the skin has as a function. Hyperkeratosis. It's that term used to describe the excessive build-up of dry skin, the keratin. Often on hands, feet, possibly legs as well, or soles of feet. It can form around wound edges, and it does really need to be removed to create that optimum healing environment. Or a callus. Now, I don't know whether you've seen any diabetic foot ulcers, for example, in your care, but again, calluses can develop, and I've seen them quite often with diabetic foot ulcers. And actually that callus needs to be removed. That thickened and hard skin to the peri-wound really does need to be removed in order to help support an optimum healing environment. Eczema, the inflammation of the skin. Again, it can be itchy. The cause is sometimes unclear. And actually what we need to do is try to manage the eczema for the patient and calm that inflammatory response to be able to help with wound healing and creating, again, that optimum healing environment. So just to sum up on that peri-wound skin assessment, we should be able to notice the overall condition of the wound and surrounding skin to the wound. And that will give us a real indication of the status of the wound, where the wound is at in its healing trajectory, and what we need to do to get that to move on with its healing. So our management plan is really key, and we identify our management plan by undertaking the holistic and really thorough wound assessment, looking at all of the parameters that we've just gone through. Further investigations that we might want to undertake could be blood tests. We might want to do a wound swab to identify potential infection. In leg ulcers, we might want to do an ABPI assessment and a full lower limb assessment to identify whether a wound is likely to be arterial or venous in its appearance. That can also help us to identify whether there's an underlying cause that needs addressing with a vascular team, for example. Or pressure and pressure perception. We might want to do a more thorough diabetic foot assessment to see if somebody has sensory neuropathy, for example. So we now move on to documenting the wound assessment. We touched on this a little bit as we've gone and touched on the importance of documenting all of the elements of the assessment that we've looked at. But it really should be clear and concise. We should only be documenting the facts either positive or negative, but it should only be the facts that we're looking at. So again, the relative negatives, things like the patient is not diabetic and has no evidence of sensory neuropathy. That's something that should be documented. A relevant positive, having a long history of smoking 30 cigarettes a day, for example. We need to be looking at that and identifying that as an impact on healing. So our patient records need to be kept factual, relevant, consistent and accurate. That will also help if we have multiple clinicians managing the same person's care. If we're factual, relevant, consistent and accurate with everything that we document, it will give the person, the clinician after us that's visiting that patient or seeing that patient in the clinic, the ability to really identify what the wound was like in their last dressing change and what it's like now. Our documentation should be written really as soon as possible after the event so that it's fresh in our minds and we're only documenting the information that is factual and relevant. It should be written clearly and it should be able to be read by other clinicians. We need to document any decisions that we've made and any conversations that we've had with our patient in regard to their care. It needs to be dated, timed and signed, and it really does need to be legible. So examples of information that we would record would be family history, our social history, any test results, the skin and wound examination, the treatment plan that we've identified, the diagnosis of what we found, have we had any test results to back our findings, which medications is someone taking. All of this is factual evidence that we need to be recording. So how do we document wound assessment? Well, we can do it in this sort of three-step approach, the triangle of wound assessment as we see it. So we can document about the wound edge, the wound bed and the peri-wound skin. And each of those can be broken down into what we then identify as our management goals. And that gives you that really structured approach and allows for the documentation to be kept manageable and to form part of your management plan and really identify the objectives of the wound. So the documentation associated with the triangle of wound assessment, it really is intuitive documentation and it's really simple to use, and you can see it here on the screen, and it goes through and it's almost a step-by-step of what you're seeing with this wound and what you're identifying, allowing you space for measurements and taking into account any signs of infection. So it really is thorough documentation. You should also confirm your action plan with your patient. What is it that you're going to be doing? What is it that you're trying to achieve? Are there any other special investigations or tests that this patient needs to undergo? For example, a lower limb assessment and an ABPI. You need to give details of specific treatment to your patient and also start planning their discharge from the moment that they come to you. Patients can sometimes become quite reliant on us as healthcare professionals, and they worry about being discharged from our care, thinking that they're not going to be able to manage on their own. Where actually, if we set that expectation from the beginning, that actually they will be discharged from our care at some point, then it's much easier to do that later down the line when they're ready to be discharged. We need to involve our patients at every step. As the treatment plan changes, if we've done a reassessment and we need to change treatment, they need to be involved in that, and we need to have discussions with them and bring them on board. We can also be looking at shared care with our patients and really getting them to help self-manage sometimes if it's appropriate. It's important to confirm this plan with our patients and get them on board with the care, because they're more likely to want to be involved then if they understand why and what's happening. We know that if somebody is involved in their care and if they are compliant with their compression therapy, for example, that they're less likely to return to us with a reoccurring ulcer if they know the reasons behind wearing compression hosiery. We need to get them on board and get them to understand that they are part of their wound healing journey. So in summary, wound assessment actually is a very complex process, and it helps us to determine what the cause of the wound is and how we can help this wound progress to healing over time. The patient consultation is really key to the assessment, and we need to allow ourselves the time to undertake a really thorough assessment to start with, identifying the causes and putting in appropriate treatment plans and making decisions on somebody's management of the wound with them involved in that discussion. Wound assessment should be based on a structured approach, for example, the triangle of wound assessment, which we've gone through today. That way, the non-healing wounds can be identified early and appropriate management and treatment of these wounds can be put into place to be able to really help somebody get to an optimum healing environment as quickly as possible, meaning that they're going to be living with that wound for less length of time and really helping them to progress to healing so they can get back to their normal day-to-day activities. Thank you for joining us for today's session. And please, if you have any further questions, then feel free to reach out to your local Coloplast representative who will be happy to help.